All right, future plastic surgeons, let's dive right in. The FRCS is coming up, and today we're tackling that hand and wrist exam. Got to be ready for the practical, right?
Got to know those high yield points, those clinical tests examiners love.
That.
Yeah, think of this like a super focused revision session.
Love it. So let's kick things off with history. Taking our source material makes a big point about trauma versus non-trauma cases. What are the key things to focus on in each scenario?
When it's trauma, you've got to zoom in on the mechanism of injury. I mean, it's not just, oh, they fell. It's fell from how high, onto what exactly, with how much force, the kind of detail helps you really anticipate the potential damage.
So like painting a really clear picture of what happened. What about those non-trauma cases? What's crucial there?
Timeline. Timeline is key. When did the symptoms first show up? How have they changed over time? What makes them better or worse? Looking for those patterns, those clues that point you towards the root of the problem. And don't forget those past injuries or problems with other joints.
Right? That context is so important.
Yeah.
Let's say we're dealing with an acute hand injury. Our source lays out 7 critical assessments. Viability vascular injury compartment syndrome. Oh, that sounds serious. Tendon and nerve damage, skeletal stability and skin loss.
It's like a mental checklist.
Right.
A rapid fire assessment to make absolutely sure you're not missing anything that could be life or limb threatening. Got to quickly figure out how bad it is and what to do next.
Okay, so you've triaged the situation. Now it's time for that more in-depth physical exam.
Mm-hmm.
Starting with the skin, what are the key things we're looking at?
Visual inspection, that's where it all starts. Look for swelling, any color changes, moisture levels, is the skin dry or clammy, and those papillary ridges really important. Don't forget, denervated skin won't wrinkle after being in water.
That's a really interesting point, and it seems like comparing the injured hand with the uninjured one is a good strategy.
Absolutely, it gives you that baseline and helps you pick up those subtle differences you might miss otherwise. Okay, now let's move on to motor function. We need to assess both active and passive range of motion and pay close attention to how much pain the patient's in.
So if they're yelling when you barely touch their finger, that's a huge red flag, right?
Exactly. Severe pain with passive movement that could signal something serious like compartment syndrome or an infection. And watch that cascade of fingers. Can they fully extend and flex each joint?
Next up is sensation testing. The source distinguishes between static and dynamic 2-point discrimination. What's the difference and why does it matter?
Okay, so static 2-point discrimination tells you the smallest distance where 2 points can be felt separately when you press them at the same time. Dynamic 2-point discrimination, well, that measures the distance when 1 point is moved across the skin. It's a more sensitive test, so it can pick up on those more subtle nerve problems.
So it's like a higher resolution image of how the nerves are working. The source also talks about sweating papillary ridge loss and the skin wrinkling test. We touched on that. But then there's this 10 test, which sounds interesting.
Oh, the 10 test is so simple but effective. Ask the patient to rate the feeling in the injured area compared to a 10 in a normal area. Quick, easy, and it's surprisingly accurate.
Okay, moving on from sensation, what about the vascular assessment? What are those must-do checks?
Got to feel those radial and ulnar pulses. Check that capillary refill. You know how fast the color comes back after you press on the nail. And don't forget Allen's test. It's a classic for checking how well the arteries are working.
And if there's any doubt about blood flow, Doppler ultrasound can give you that extra information.
Yeah.
Now, for the skeletal assessment, the source really emphasizes checking for swelling deformity and any limits in range of motion.
It's all connected. Swelling can restrict movement. Deformity could mean a fracture and tenderness. Well, that helps you pinpoint exactly where the problem is.
And last but not least, radiographs are always important, but what are the key takeaways for the exam?
Be thorough. Get those PA and lateral views and add more views if you need them. And don't hesitate to get comparison views of the other hand, especially with children. It can help you spot those sneaky fractures that you might miss otherwise.
Makes sense, especially when those bones are still growing. So we've covered that general hand exam, but now let's get specific. The source really dives into detailed motor exams for different muscle and tendon groups.
Let's run through some examples and those key instructions you'd give to the patient during the exam. Okay, so let's get into those specific motor tests. Got to really isolate individual muscles and tendons, to pinpoint any weakness or dysfunction.
All right, so we're getting down to the details here. We've already talked about the FPL and FTP for thumb and fingertip flexion. What about that flexor digitorum superficialis, the FDS? How do we test that one?
For the FDS, isolate each finger and have the patient bend your finger at the middle joint while you hold the other finger straight. You're specifically looking for that flexion at the PIP joint.
Got it. Now, moving on to the thumb, we've got the abductor pollicis longus, or APL, and the extensor pollicis brevis, EPB. How do we assess those?
Have the patient bring their thumb out to the side. You'll feel those tendons tighten up on the thumb side of the wrist. That's thumb abduction.
Okay, on to those wrist extensors, the extensor carpi radialis longus and brevis ECRL and ECRB. How do we test those?
Tell the patient to make a fist and really bring your wrist back. You'll feel those tendons working on the back of the wrist towards the thumb side.
So we've covered thumb flexion, finger flexion, thumb abduction, and wrist extension.
Yeah.
What about the extensor pollicis longus, the EPL?
Remember that thumb lift-off test, hand flat on the table and lift only your thumb? Isolates the EPL perfectly.
Okay, now those finger extensors. We have the extensor digitorum convenus EDC, extensor indicis proprius EIP, and extensor digiti minimi EDM.
How do we tell those apart?
It's all about selective finger extension. For
Right.
the EDC, it's straighten all your fingers. For the EIP, it's stick out your index finger while making a fist with the others. And for the EDM, same thing, but with the pinky finger. Really putting those fingers through their paces. Now, what about the extensor carpi-ulnaris, the ECU? How do we assess that?
Ask the patient to pull your hand up and out to the side towards the pinky side. You should feel that tendon pop on the outer edge of the wrist.
Okay, moving on to the keen arm muscles, those ones that control thumb movements. We have the abductor pollicis brevis, APB opponens, pollicis OP and flexor, pollicis brevis FPB.
The classic test for these is thumb opposition. Touch your thumb to your little finger. It needs all three muscles working together.
Got it. Now the adductor pollicis, or ADP, the source mentions something called Froment sign. What's that all about?
Froment sign is a really clever way to test the ADP. Have the patient grip a piece of paper between their thumb and index finger. If the ADP is weak, they'll compensate by bending the tip of their thumb to hold on. That's a positive Froment sign.
Interesting. So weakness in one muscle can actually change movement somewhere else. It's all connected. What about those interosseous muscles, the ones that spread the fingers?
To test those, have the patient spread their fingers apart while you give them some resistance. You're directly checking how well they can abduct and adduct the fingers.
Makes sense. Lastly, we have those hypothenar muscles controlling the little finger. The source lists the abductor digiti minimi ADM, flexor digiti minimi FDM, and opponens digiti minimi ODM.
To assess those, ask the patient to move your little finger away from the others. Simple test that isolates those hypothenar muscles.
Okay, we've covered a whole bunch of specific motor tests. It's amazing how each muscle group has its own little test to see how well it works. What about the sensory exam? What are the key things to remember there?
Knowing your dermatomes is super important. Those areas of skin supplied by specific nerve roots. You've got to know the ulnar median and radial nerve territories in the hand, like the back of your hand. The source has some great diagrams if you're a visual learner.
Right, because if someone has numbness on the tip of their index finger, you immediately think median nerve.
Exactly. It helps you pinpoint the problem. And don't forget that two-point discrimination testing, both static and dynamic, it gives you a more precise measurement of sensory function.
Okay, so we've gone through history, taken the general hand exam, specific motor tests, and the sensory exam. We've hit all the major points for the FRCS, haven't we?
We have, and remember, practice, practice, practice. The more you do these tests, the more confident you'll be. And don't forget, those examiners, they're looking for your clinical reasoning skills just as much as your knowledge.
It's not just about checking things off. It's about showing you can put the pieces together and use that knowledge in real-life situations.
Absolutely. So keep prepping for the FRCS and focus on understanding the why behind the what. That's what'll make you stand out and help you ace that exam.
It's like having this mental map of the hand, right?
Mm-hmm.
But speaking of maps, let's talk about those clinical tests for specific conditions. The source mentions tenderness in the anatomical snuff box. Can you remind us what that is and why it's so important?
Oh yeah, the anatomical snuff box, that little dip on the thumb side of the wrist formed by the tendons. Tenderness there, that's a classic sign of a possible scaphoid fracture.
Right, one of those high-yield exam points. The source also talks about the grind test used to check for arthritis in the thumb's main joint. How does that one work?
You gently press and rotate the joint. If there's pain, that's a positive grind test. It could mean degenerative arthritis in that subcarpometacarpal joint.
And then there's Finkelstein's test. I remember learning about that one in med school. It's for diagnosing de Quervain's tenosynovitis, right?
Exactly. Have the patient tuck their thumb into their fist and then bend the wrist towards the little finger. Pain along the thumb side of the wrist, that's a positive. Finkelstein's test points towards de Quervain's.
Okay, now on to some tests for carpal tunnel syndrome. The source mentions Tennel's sign. Remind us what that involves.
Tinel sign, you lightly tap over the median nerve at the wrist. If it sends tingling or numbness into the hand, that's a positive. Tinel sign could be carpal tunnel syndrome.
And then we have Phelan's maneuver, another classic for carpal tunnel. How do we do that one?
Have the patient hold their wrists flexed for a minute, pressing the backs of their hands together. If it brings back their symptoms, that's a positive. Phelan's maneuver supports a carpal tunnel diagnosis.
And finally, there's Durkin's compression test. What's the idea behind that one?
Durkin's test, you directly compress the median nerve at the wrist for about 30 seconds. It's a more specific way to trigger those tingling or numb feelings that come with carpal tunnel.
So we've covered a whole range of tests for the hand and wrist, from basic anatomy and how it works to those specific techniques for common conditions. It's a lot to take in, but I feel like this deep dive has really helped me solidify my knowledge and given me a good framework for the exam.
Absolutely. The key is to practice, practice, practice. The more you do these tests, the more confident you'll get. And don't forget, those examiners are looking for your clinical reasoning just as much as what you know.
Right, it's not just about checking off boxes. It's about showing you can connect the dots and use your knowledge in real-life situations.
Exactly. So as you keep studying for the FRCS, focus on understanding the why behind the what. That's what will help you really stand out and do great on exam day.
That's some great advice. And with that, we'll wrap up this deep dive into the hand and wrist exam. We hope it's been helpful, and we wish you the best of luck on your FRCS journey. We'll see you on the next deep dive.